The posterior superior alveolar nerve block is used to produce anesthesia of the posterior maxilla. Usually, all three maxillary molars are anesthetized, along with the surrounding periodontium and maxillary buccal mucosa. However, a separate supraperiosteal injection over the maxillary second premolar, or mesial buccal root of the first molar, is required to ensure complete anesthesia of the first molar. The target site for the posterior superior alveolar nerve block lies on the posterior aspect of the maxilla, about 1 centimeter above and medial to the apices of the third molar. The nerve enters the maxilla here through one or more foramina. Because this area is convex, the needle must be oriented backward, upward, and inward.
For a right-handed operator performing a right or left posterior superior alveolar nerve block, the clinician may be seated in the 11 o'clock position with the patient's neck extended and the head turned to permit visualization of the maxillary buccal vestibule. Once a finger has been placed in the vestibule, the mouth is partially closed and the jaw is moved laterally to the side of injection. This maneuver relieves tension on the cheek and moves the coronoid process away from the injection area. The needle puncture point is in the height of the vestibule immediately behind the zygomatic process. It is normally situated between the distal buccal root of the second molar and the mesiobuccal root of the third molar. The zygomatic process is easily identified by gentle palpation buccal to the first molar. As the probe is moved posteriorly, it falls behind the process, indicating the insertion site. The distal boundary of the zygomatic process is palpated. The needle is carefully advanced to the insertion point and oriented medially as well as posteriorly and superiorly. For the average adult, the needle axis should be at an angle of 45 degrees to all three planes. The needle is slowly advanced to a depth of 15 millimeters. After careful aspiration, 1/2 to 1 cartridge of anesthetic solution, or about 1 to 1.8 milliliters, is slowly injected. With the proximity of the posterior superior alveolar artery and the pterygoid venous plexus, hematoma formation is a potential complication. This risk, quite low with proper technique, is increased if the needle is inserted too far laterally and especially if it is redirected while embedded in tissue. Both errors tend to occur when the operator allows the cheek to torque the syringe medially during injection. If the insertion point is too anterior or too close to the alveolar process, or if the angulation is too vertical or too medial, premature contact with bone will occur. In these situations, the needle should be withdrawn and correctly repositioned for a new straight insertion.